approach to your various oral hypoglycemic agents and insulin treatment. Okay, so first stage here, you have number 1. The final common denominator is beta cell damage, the pancreatic beta cells in the islets of Langerhans. So you have here decreased beta cell function, decreased beta cell mass. So what happens if you have this beta cell destruction or damage? Decreased insulin, or the final common denominator. Okay, so number 2, you have decreased incretin effect, your hormones that are used for gastric emptying. Then alpha cell defect. As a result, there will be increased glucagon that can cause hyperglycemia. Then number 4, increased lipolysis in the fat cells. So there is no uptake of glucose into the fat cells, decreased uptake of glucose in the muscle cells. So there will be decreased peripheral muscle uptake. Then in the liver, there is increased glucose production or increased hepatic glucose production. Okay, so HPG increase. Then in the brain, what happens? There will be increased appetite, decreased morning dopamine surge, increased sympathetic tone. That can more or less increase your norepinephrine. Okay? Then number 8, you have colon microbiota or biome. There will be an abnormal microbiota, possible decreased GLP-1 secretion. Okay? So again, what is your GLP-1? That is one of your hormones or your incretins. Okay? Number 9, immune dysregulation. You have here inflammation. What is considered as an anti-inflammatory hormone? Can you still remember? GLP-1, di ba? I mentioned that. And then decreased amylin. Decreased amylin. There, I mentioned an amylin analog. What is that amylin analog? Pramlintide. Very good. You have remembered it, huh? Okay. Number 10, stomach or small intestine. You have here increased rate of glucose absorption. Increased rate of glucose absorption. And we have one class here of medications that can decrease glucose absorption or increase glucose elimination in the gastrointestinal tract. And you have here your alpha glucosidase inhibitors. And then in the kidneys, you have here increased glucose reabsorption or your SGL2. Then you have here, you should use drugs that can inhibit this SGLT2 or your sodium glucose cotransporter 2. Very good. No? So I observe in this class you are very fast in remembering the things that I have mentioned. Okay? Yes, yes. Okay. Very good. Okay, for those who want to have some fun, okay? Sorry, I did not. Okay, 5 minutes break. So stretching exercises. Okay, you can do like this. No, you can do TikTok.
Excuse me, Doc. Excuse me, Doc. Did you hear me?
Ngayo break. Naay, gikuan si Doktora. Doktora Alarcon for 15 minutes nga kuan. Na post test.
Tapos test na. Masa sa assign ako.
Doktora. Oh, Doktora Alarcon. Where you kumukuan?
After ano ba? Lecture.
Oh, mga at 10:45. Sorry at Hey, ma-receive din mo. Sige, sige. Oh, sige, sige. Oh, sige, thank you. Okay. Again, remember you will have a post test at 10:45, Just the same last time,
Hello. Di ba? Post na daw ang post test.
Oo.
Di pa lang ma-view.
Oo.
At 10:45
Ay,
na.
10:45. Iko. Okay. There is a post test. You can open it at 10:45 pa, ha? So we have to finish na. Okay? So, can we go back? Okay. Okay, now how do you screen a patient for diabetes? Huh? Where?
Online, check. There's a question for student, it seems to us. I saw, sir, it's not there.
I don't know.
Someone is asking if they have a question.
Okay. Wara. So,
Yes, may I
Yes.
ask the question about the group 21 we still didn't present
yes.
about last semester. We got some topic, but we still didn't present. May I know the schedule to present the
So you can you are going to present. I will tell Dr. Alarcon, ha? She said the last time I talked to them, you are now going to more or less submit
Thank you.
submit a paper for that.
Okay.
Your group will just have to submit. I think we only have one group that has not presented, diba?
Yes. Maybe.
And then the other one, the pharma section D R2, they are also one group. Then we will require them to submit also the same as what you will be going to do, no? Submit a written report, okay?
Okay. Thank you, Doc.
Okay, so we will post also in our group chat, okay? Later. I will tell Dr. Alarcon, the new chair.
Thank you.
Okay? Okay. So I hope that has answered your question or your query. Okay, now screening for diabetes. A1C stands for glycosylated hemoglobin. Now, what is the importance of this glycosylated hemoglobin? Anybody? It will help you. Okay, so this will more or less reflect your blood glucose level control for the past 3 months. That's why you are going to, after giving your patient some medications for diabetes mellitus, and then you want to know whether you have some progress in your manner of treatment, you will order for a glycosylated hemoglobin or A1C, hemoglobin A1C, or fasting prandial glucose. Okay? Prandial glucose or an oral glucose tolerance test, OGTT, 75 grams. Those are your screening for diabetes. Now, testing should be considered in all adults who are overweight. That means BMI equal or more than 25 kilos per meter square. I know in your biochemistry, you have been told how to compute for your BMI. Can you still remember how to compute for your BMI? And it is very important for you as medical students now to compute your own BMI so that you will know whether you are overweight, you are underweight, or you are obese 1 or obese 2. That can more or less give you a prognosis and how you are going to fare health-wise. Okay? So, BMI is computed as height in centimeters. Okay, height in meter square over weight in I think it's the other way around, no? It's there, no? Kilogram over meter square. Okay? So, I ask you to compute your own BMI so that you will know whether you are overweight, you are underweight, or you are normal. That's very good if you are normal, or obese 1 or obese 2. Okay. Okay, so what will be the risk factors for screening? So you have to more or less encourage this person for screening. Physical inactivity, first degree relative with diabetes, high risk race, ethnicity, African, American, Latino, Native American, Asian American, Pacific Islanders. Women who delivered a baby weighing 9 pounds or more. That can more or less be a diagnosis for gestational diabetes mellitus. And then hypertension, 140 over 90 millimeters, mercury or an therapy for hypertension, high density lipoprotein, your good cholesterol, which is less than 35 milligrams per deciliter, or a triglyceride of more than 250 milligrams per deciliter. What is your normal triglycerides by the way? Normal triglycerides. Okay, 150. So those with more than 250 milligrams are candidates for diabetes, no? Then women with PCOS. What is PCOS? Polycystic ovarian syndrome. Then hemoglobin A1C, more than 5.7%. Okay, IGT or IFG, impaired plasma glucose on the previous testing. What is considered as impaired plasma glucose? Glucose level of how much? 100, more than 100 to 126. These are considered as impaired plasma glucose. And then other clinical conditions associated with insulin resistance, you have severe obesity, so obese 1 or obese 2, and then acanthosis nigricans. What is this? Acanthosis nigricans. This is black discoloration in the naves. Okay? Black discoloration in the naves. Then history of cardiovascular diseases. Okay, gestational diabetes mellitus, overnight fast, 75 grams, oral glucose tolerance test, fasting, 92 milligrams per deciliter, 1 hour, 180 milligrams per deciliter, then after 2 hours, 153 milligrams per deciliter. And then in the absence of the previous criteria, testing should begin at age 45. If there are normal results, repeat at least 3-year intervals. Consider more frequent testing depending on the risk status. At risk BMI may be lower in some ethnic groups. You have your Native Americans. So these are now your diabetes diagnosis. Okay? So normal, what is the normal level for your fasting blood glucose? Less than 100. How about for 2 hours, 75 grams oral glucose tolerance test? Less than 140. It's there. Oh. Then glycosylated hemoglobin should be less than 5.7. Are you getting it? Okay, again, normal is fasting blood glucose should be what? Less than 100. 2 hours, 75 grams oral glucose tolerance test. Less than 140, then glycosylated hemoglobin should be less than 5.7. Okay, pre-diabetes. I said, in your fasting blood glucose, a pre-diabetic patient will reflect a 100 to 125 milligrams. And then 2 hours, 75 grams oral glucose tolerance test, it's 140 to 199. Then glycosylated hemoglobin, which will more or less tell you how you are having your patient's blood glucose control in the past 3 months. You have here 5.7 to 6.4. That is pre-diabetes. Now, you will say that the patient is now diabetic if the fasting blood glucose is equal or more than 126 milligrams per cent. Your 2 hours, 75 grams oral glucose tolerance test is equal or more than 200 milligrams, and your glycosylated hemoglobin is equal or more than 6.5. Okay, so please memorize that. Please be aware of that because you will really appreciate it when you will be going into your practice. Okay? Determinations and decisions, decision making, and how you are going to approach your patient with diabetes mellitus. Okay? So in patients with classic hyperglycemic symptoms with plasma glucose of more than 200, and you have a condition known as metabolic syndrome. We have discussed this already. Okay? Now, gestational diabetes, screen for type 2 diabetes, first prenatal visit, if with risk factors. Not known to have diabetes, screen for gestational diabetes mellitus at 24 to 28 weeks of gestation. Then screen women with gestational diabetes mellitus for persistent diabetes 6 to 12 weeks postpartum. Then women with a history of gestational diabetes mellitus, lifelong screening for diabetes or pre-diabetes at least every 3 years, up to 7 times higher risk than non-gestational diabetes mellitus. Okay, so that is how you are going to approach or treat your patient in gestational diabetes. Okay, so take note of the schedules of follow-ups. Hello? Okay. Then target for glycemic blood sugar control in most non-pregnant adults. So in American Diabetic Association, your glycosylated hemoglobin should be less than 7. In your European group of endocrinology, you have less than 6.5. Fasting blood glucose should be 70 to 130. Here you have 110 milligrams per deciliter. Postpartum after meals plasma glucose, you have less than 180. Here in your endocrinology, you have 140. Lifestyle management, you should have a medical nutrition therapy or MNT. Exercise activity prescriptions, almost everybody can do something. So lifestyle modification, indicated in all patients with diabetes. Okay. What do you mean by lifestyle modification? Anybody here? Hello? Lifestyle modification. Huh? Eliminate or stop all those activities or habits that can more or less increase your cardiovascular risk and eventually diabetes mellitus. Because you know diabetes mellitus is associated with the risk for end organ. You will have damage to your end organs, such as, what are your end organs? The brain, the heart, the kidneys. Okay? Those are the things, and the lungs. Okay, so diagnostic procedure here. Glycosylated hemoglobin, fasting blood sugar, postprandial or oral glucose tolerance test using a 75 grams. Okay, glucose A1C. Okay, less than 7, equal or less than 6.5. So your goals of therapy here, your target goals. Fasting blood sugar should be what? 70 to 130. Postprandial should be less than 180 after 2 hours. Glycosylated hemoglobin should be 7% or less. BP should be less than 130/80. Lipid panel, total cholesterol should be less than 200. Triglyceride should be less than 150. Your good cholesterol or your high density lipoprotein in men should be more than 40. In women, it should be more than 50. Your low density lipoprotein or bad cholesterol should be less than 100, less than 70 for those with coronary artery diseases, cerebrovascular diseases, or high-risk persons. Okay, so let's go now to the treatment of diabetes mellitus. So we are now go into pharmacology or the drugs that you are going to consider. Okay, so you have now, I introduced to you the ominous octet. What are your ominous octet? Decreased insulin secretion, decreased incretin effect, increased lipolysis, increased glucose reabsorption, decreased glucose uptake, neurotransmitter dysfunction, increased HGP or hepatic glucose production, increased glycogen secretion in the islet alpha cell, and decreased insulin secretion. Okay? I hope you are following this ominous octet. Okay, so in type 2 diabetes, you have the following drugs, your secretagogues, or those that can more or less promote insulin secretion. You have sulfonylureas, insulin, and meglitinides. Then your insulin sensitizers, you have thiazolidinediones and metformin. Then your glucose inhibitors for reabsorption, you have acarbose, GLP-1 analogs, and DPP-4 inhibitors. Hello? You have to follow up this so that you will know the mechanism of action of these different classes of diabetes mellitus drugs. Okay? So I have mentioned to you your hormones. In the gastrointestinal tract, you have your incretins, your GLP-1 analogs, and your DPP-4 inhibitors. Then in the kidneys, you have here your SGLT2 inhibitors or sodium cotransporter type 2. Okay? I hope you know the acronyms of this, no, or the meaning of SGLT2, and then your AGI or glucosidase, alpha glucosidase inhibitors, then GLP-1 analog and DPP-4 inhibitors. These are the different groups of your oral hypoglycemic agents and your injectable. You have your insulin. Any questions so far with this? So we're now going to the different classes of oral anti-diabetic drugs, no? So you have here, I review here, you have here your decreased beta cell function, decreased beta cell mass, and there is decreased insulin. So what are the drugs that you more or less can give here? Incretins and ranolazine. Okay, so decreased incretin effect, you can give incretins. Then alpha cell defect, you have here incretins and pramlintide. Then in the kidneys, you have your SGL2 inhibitors. In the brain, you have incretins, dopamine agonists, or appetite suppressants. Appetite suppressants, your diet drugs, no? And then insulin resistance here, Insulin resistance in the liver, you can give metformin and thiazolidinediones. In the muscles, you have thiazolidinediones and metformin. In the adipose tissues, you have thiazolidinediones and metformin. These are actually your insulin sensitizers, the ones that targets insulin resistance. Are you following? You have to differentiate between sensitizers and secretagogues. What do you mean by secretagogues? Those drugs that can more or less increase insulin secretion. Okay. How about sensitizers? Those that can more or less decrease insulin resistance. Okay? So, try to know these groups, And then, colon in the biome, you have here probiotics, incretins, and metformin. And in the immune dysregulation or inflammation, you have here incretins, anti-inflammatories, and immune modulators. And then you have here amylin, no? Amylin is exemplified by your amylin analog, pramlintide. Okay. And then in the stomach, you have here your GLP-1 agonist, pramlintide, and alpha glucosidase inhibitors. Alpha glucosidase inhibitors. No questions so far? So we are now in your oral hypoglycemic agents. Oral hypoglycemic agents. Oral hypoglycemics, type 2 diabetes, generally results from either a decrease in insulin resistance or insulin activity. Give me an example of a drug that can cause or target insulin resistance. Metformin, very good. Insulin secretion. Sulfonylureas, very good. The use of oral medications with diet and exercise can manage the problem, but oral hypoglycemics are not insulin and therefore cannot replace insulin. You are aware of that, no? Hypoglycemics help the body better utilize or make insulin. Beta cells must make enough insulin to work, otherwise combination with insulin is necessary. General guidelines in elderly non-obese patients, short-acting insulin secretagogues. Give me an insulin secretagogue. Sulfonylureas can be started, but long-acting sulfonylureas are to be avoided in elderly. And then you must monitor the kidneys, renal function. And then oral antidiabetic agents are not recommended for diabetes in pregnancy. And then oral antidiabetic agents are usually not the first line therapy in diabetes, especially diagnosed during stress such as infections. Insulin therapy is recommended for both and above. So really it's insulin, no? Especially for pregnant women. Targets for control are applicable for all age groups. However, in patients with comorbidities, you should individualize your drugs. So individualize. And then when indicated, start with a minimal dose of your oral anti-diabetic agent while re-emphasizing diet and physical activity. An appropriate duration of time, around 2 to 16 weeks, depending on agents used, between increments should be given to allow achievement of steady-state blood glucose control. So what are your classes of oral hypoglycemic agents? Classes of oral hypoglycemic agents. Okay, those that target insulin secretion or insulin secretagogues. Okay, these are your sulfonylureas. Example is glibenclamide. Meglinides, example is ripaglinide. Please try to absorb it. Okay, because the next problem that you will have to do is to decide what oral hypoglycemic agent are you going to use, and then the dose and the strength of the medication. That's how it is to become a doctor. Huh? Remember, you are not James Bond, who is licensed to kill. You are a physician who is licensed to heal. So you have to be very careful, no? So target insulin secretion, you have sulfonylureas, glibenclamide, meglitinides, ripaglinide. Target insulin resistance. So these are your sensitizers. You have here biguanides. So I want, what is that what I want is that for you not to confuse between secretagogues and sensitizers. Okay? So target insulin resistance, you have here biguanides, exemplified by metformin, thiazolidinediones, exemplified by rosiglitazone. Those that targets glucose absorption from the intestine, that inhibits glucose absorption and excretes glucose in the gastrointestinal tract. You have here your alpha glucosidase inhibitor, exemplified by acarbose. Acarbose. Okay, so these are now your oral hypoglycemics. You have here your acarbose in the gastrointestinal tract that will more or less prevent or inhibit reabsorption of glucose in the GIT. Then you have your sulfonylureas and miglitinides, which are used to secrete or enhance insulin secretion. You have here your metformin and thiazolidinediones, which will more or less decrease resistance to insulin in the liver, in the fat cells, and in the muscles. And you have here your thiazolidinediones and metformin. This is in the muscle cells. Okay, so let's first go to the biguanides or metformin. Okay, the biguanides or metformins. This will decrease insulin resistance. So there will be decrease in hepatic glucose output, increased peripheral uptake of glucose into the liver, the fat cells, and into the muscles. Monotherapy, you can give it as single dose or as an adjunct to insulin. It does not produce weight gain. So this is very good for those who are chubby, no? Okay? So does not produce weight gain in contrast to sulfonylureas. Useful in obese clients. So what are examples of branded metformin? You have Glomet, Diaformin, Glofocofads, and Neoform. I want you to know that we have a drug index. In the Philippines, you have your MIMS, which you can more or less consult to if you want to know the strength of the preparation, how is it prepared, and then the doses, special precautions, and adverse reactions. Please try to know that. Huh? Have you opened already a MIMS? This is very important for you. Okay? MIMS. Updated list of drugs that you can avail of within the Philippines. Okay? Okay? So dose of your metformin is 500 milligrams daily, increasing gradually to 500 milligrams 3 times a day. Maximum dose is 3 grams. Most can only tolerate 2 grams a day. Okay. Okay, so it has been found out that metformin can reduce glycosylated hemoglobin by 1 to 2%. Contraindications, they may provoke lactic acidosis, and this is contraindicated in patients with renal impairment. Then you have liver and heart failure, severe dehydration. I repeat, contraindications to the use of metformin, lactic acidosis, renal impairment, liver and heart failure, severe dehydration. Side effects, nausea and vomiting, diarrhea, abdominal discomfort, impaired B12 absorption. So what will be the result if there will be impairment of B12 absorption? What happens? Huh? Okay, so how are you going to counteract this? Together with metformin, what are you going to give? Vitamin B complex. Okay, vitamin B12. It's in the B complex tablets. Okay, sulfonylureas, they are insulin secretagogues. It will stimulate beta cells to release insulin from your functioning pancreatic cells. Examples, glibenclamide, marketed as Downell, Glymil, widely used. These are long-acting. You should avoid this in elderly or in patients with renal impairment. Then glycoside, marketed as Diamicron or Nidem, glypeside, Minidiab or Milicide, glimepiride, Amaryl or Dimarel. The dose varies per drug. Drug interactions is multiple. Okay. Just as I have said, you can meet this medications, the brand names in the drug index or the MIBS. It will reduce hemoglobin, glycosylated hemoglobin by 1 to 1.5%. There is no lag in response. The choice of agents available will depend on the onset, duration of action, and elimination. This is the first choice in diabetics who are lean or thin. Why? In contrast to your metformin, which you can use if you are overweight or chubby. The opposite effect will be, it can cause what? Weight gain. Okay? So first choice in lean patients, the drug is broken down in the liver, so avoid in people with liver and renal impairment. Adverse effect, GI disturbances, headache, bone marrow depression, mild skin reactions, photosensitivity, mild alcohol intolerance, hypoglycemia, and weight gain. Okay, there is a 5 to 10% secondary failure rate per year. Any questions so far? Okay, I hope what you are going to use in patients who are very thin. Okay, how about if very fat? Like you? I'm just joking. Okay, long-term side effects. You have here beta cell exhaustion, secondary failure of treatment. Therefore, use short-acting versions, lowest effective doses. Then after many years of treatment, you have to evaluate your medications because the secondary failure is inevitable. Okay, next group, alpha glucosidase inhibitors. Alpha glucosidase inhibitors. The dose is 50 milligrams daily, increasing gradually to 3 times a day. If necessary, up to 200 milligrams 3 times a day. Take it with or just prior to meal. Can treat hypoglycemia due to your alpha glucosidase inhibitor with glucose or D50 water injection. Or you can just give along with you, or you can give those rabbits, no? Okay, the candy. You can give this if the patient is having symptoms of hypoglycemia, no? So Coke also can more or less give just minimal amount of this glucose-laden candies, no? You can bring it in your pockets if you have some cases of hypoglycemia, no? So 50 milligrams daily, what is the mechanism of action of your alpha glucosidase inhibitor? It will increase elimination of glucose in the gastrointestinal tract or decrease reabsorption of glucose. That's why it's termed as alpha glucosidase inhibitor. Okay? Then side effects, flatulence, diarrhea, abdominal distension, and pain. Contraindication, you have pregnancy, breastfeeding, liver and severe renal impairment, inflammatory bowel disease, and intestinal obstruction. So again, what is the mechanism of action of your alpha glucosidase inhibitor? It will inhibit your enzyme, alpha glucosidase. That can cause what? Inhibition in the reabsorption of glucose in the gastrointestinal tract. Okay, so mechanism of action reduces glucose absorption from the gut by inhibiting the breakdown of disaccharide to monosaccharides. So that is the specific mechanism of action of your alpha glucosidase inhibitors. Glucose is monosaccharide, di ba? Okay, so it will inhibit the breakdown of disaccharide to monosaccharide. So therefore, it will just stay as disaccharide, so it will be eliminated in the gastrointestinal tract. It will be not absorbed in the GIT. Only effective if taken at the same time as food, as drugs needs to reach intestine at same time as foods to work. Example is acarbose, marketed as glucobay. Monotherapy can be started or as an adjunct. Okay, or as an adjunct. Then, what's the mechanism of action of your alpha glucosidase inhibitors? Okay. Okay, so in therapy, add on to treatment with metformin or sulfonylureas, part of a triple therapy. You can also do this as monotherapy with insulin or in type 1 diabetes. It can reduce your glycosylated hemoglobin by 0.5%. It is safe, weight neutral, dose coupled with meals. Just monitor during your first 6 to 12 months. So the levels of these drugs. Next group are your meglitinides. Meglitinides. Okay, your gliptins. Prandial glucose regulators. It will stimulate beta cells to release insulin. Stimulate beta cells to release insulin response. However, it is glucose dependent. Following meals, there is an early phase insulin release. In type 2 diabetes, this is lost causing postprandial spikes. PGR can mimic release of physiological insulin as they are short-acting and do not stimulate the beta cells constantly. Okay? So what are your prandial glucose regulators? They are your meglitinides or your gliptins. Okay, so meglitinides marketed as Novomorm. So you have here ripaglinides. This is initially 500 micrograms up to 4 milligrams as a single dose. Must be taken within 30 minutes before a meal. Contraindications, diabetic ketoacidosis, pregnancy and breastfeeding, type 1 diabetes, severe hepatic impairment, especially with ripaglinide. Monitor them periodically. Okay, what is ripaglinide? Novomorm or an example of a glutinide. Hello? Now, this will quickly lower your postprandial glucose levels. There is no lag before response. It can decrease your glycosylated hemoglobin by 0.5 to 2%. It has a short half-life, mealtime flexibility. It can decrease the risk of weight gain. Next are your thiazolidinediones. Classify this. Is it an insulin sensitizer or is it a secretagogue? Huh? Okay. It will improve insulin sensitivity, skeletal muscle, adipose tissues, and the liver. So it is a sensitizer, thereby promoting uptake of fatty acids and glucose at these sites. I'm always asking you this, whether it's a sensitizer or a secretagogue, so that you will know this, how to apply in your practice, no? So actions: counteract insulin resistance, reduces hemoglobin C, HbA1c by 1 to 2%, alternative to insulin in type 2 DM only, beneficial effects on the lipids. So it can more or less decrease your bad cholesterol and your triglycerides. Example, pioglitazone, rosiglitazone, or Avandia. You can use this as an adjunct with metformin or sulfonylureas. Dose, it will vary per drug. pioglitazone 15 to 30 milligrams once daily, rosiglitazone or Avandia 4 milligrams per day, or with metformin 8 milligrams per day. Contraindications, pregnancy, breastfeeding, liver impairment, and heart failure. So remember that. Side effects, edema, weight gain, gastrointestinal disturbances, headache, and dizziness, high non-response rate. There is a delayed effect in 8 weeks. So it's not a very prompt response. Okay, so your anti-hyperlipidemics, there is one group there, your bile acid sequestrants, that can lower your low-density lipoprotein cholesterol. Colivisilam or Wheatcol, this is a bile acid sequestrants that can lower also the glucose level and A1C levels in type 2 diabetes patients. Okay, so colivisilam or Wheatcol, and a bile acid sequestrants that can, aside from lowering your low density lipoprotein or your bad cholesterol, it can also lower your glucose levels and glycosylated levels in type 2 diabetes mellitus. We have to go faster now. Now, GLP-1 receptors are abundant in the liver, in the brain, in the heart, in the pancreas, your skeletal muscles, blood vessels, kidneys, and fat cells. These are the effects. So, GLP-1, the mechanism of action, if you are full or having a full diet, your GLP-1 will be released. Okay? It can increase insulin secretion, decrease glucagon secretion, reduces hepatic glucose output, and can more or less act on your DPP4 enzyme. Okay? So, okay, so let's go to your incretin drugs. Incretin drugs. And the first column there, you have GLP agonist. Okay, exemplified by exenatide, liraglutide, semaglutide, albiglutide, taspoglutide, exenatide, and lixenatide. Are you following? Okay. For your DPP4 inhibitors, you have here vildagliptin, sitagliptin, saxagliptin, alogliptin, linagliptin, dotogliptin, metogliptin. Okay. Now, what are DPP4 inhibitors or your gliptins? What are your DPP4 inhibitors or your gliptins? These are your endogenous GLP-1 that is very rapidly inactivated by your dipeptidyl peptidase 4. That's why it's termed as DPP4. What is DPP4? Dipeptidyl peptidase 4. Okay, so this is GLP-1. Now, inhibitors of DPP4 can prolong the half-life of GLP-1. And this is exemplified by alogliptin, linagliptin, saxagliptin, sitagliptin, and vildagliptin. Okay, again, what is the meaning of DPP4? Okay, and your preparation is an inhibitor to DPP4. So that means there is no metabolism of your GLP-1. Okay, so you will now have what? Third oral agent after metformin or sulfonylureas when the patient refuses insulin injection. So you can use this as an oral agent if the patient refuses insulin. Okay? Now, patients with renal failure who decline insulin, elderly patients who avoid insulin and hypoglycemia, patients with increased incidence of hypoglycemia. Okay, so those are the benefits of using DPP4 inhibitors. Third oral agent when the patient refuses insulin, patients with renal failure who decline insulin, elderly patients who avoid insulin and hypoglycemia, patients with increased incidence of hypoglycemia. Okay. Okay, so let's go to an incretin mimetic. That means it will more or less copy or present as just like your amylin analog, pramlintide. You have an analog of incretin, you have exenatide. This is resistant to DPP4 inactivation. Following injection, it is measurable, present in plasma for up to 10 hours, suitable for twice-a-day administration by subcutaneous injection. But the problem with exenatide is the cost, plus the burden of injection. So I just want to know that you have a preparation incretin mimetics exenatide. Okay, so let's go to your SGLT2 inhibitors. What is the meaning of SGLT2? Sodium glucose cotransporter 2. Close at the back. What is the meaning of SGLT2? Sodium glucose cotransporter 2. This is a mechanism for direct glucose removal. SGLT2 inhibition lowers hyperglycemia independently of your beta cell function and insulin resistance. SGLT2 inhibitors will reduce glucose reabsorption in the site of the kidneys, proximal convoluted tubule. So inhibition of the reabsorption of glucose in the proximal convoluted tubules can lead to urinary glucose excretion and osmotic diuresis. Glycosuria, of course, no? I repeat, SGLT2 inhibitors will reduce glucose reabsorption in the proximal tubule, which can lead to urinary glucose excretion and osmotic diuresis. That means glycosuria. This is responsible for 90% of your total renal glucose reabsorption. SGLT2 inhibition will induce urinary glucose excretion, resulting in the reduction of blood glucose. So that's the mechanism of your SGLT2 inhibitors. Okay, so urinary glucose excretion via SGLT2 inhibition. So here you have your filtered glucose load of more than 180 grams per day. You give an SGLT2 inhibitor, it will reduce glucose reabsorption in the proximal tubule, leading to urinary glucose excretion and osmotic diuresis. Okay? So direct removal of glucose. Okay, so in 1933, you have here florizine extracted from the bark of apple trees, glucose ring connected to your two phenol rings via oxygen. It will inhibit both SGLT1 and SGLT2. Now, we have now your more recent SGLT2 inhibitors. First, you have your surgliflozin and remogliflozin, but the development have been stopped. Presently, you have here registered in Europe and United States. You have the three representable SGLT2 inhibitors. You have number one, dapagliflozin, number two, canagliflozin, and number three, empagliflozin. What are the three representative of your SGLT2 inhibitors that has been registered in Europe and United States? Dapagliflozin, canagliflozin, and empagliflozin. Okay, so SGLT2 inhibition can lower blood glucose independently of your beta cell function and insulin resistance. Characteristics of SGLT2 inhibitors in advanced development or launch. You have here metabolism, dual renal and hepatic, mainly hepatic, and then mainly hepatic. So you have here empagliflozin, dapagliflozin, and canagliflozin. And dosing is your oral administration, 10 milligrams and 25 milligrams for empagliflozin. Once a day also for 5 milligrams and 10 milligrams dapagliflozin. And 100 milligrams and 300 milligrams canagliflozin. Okay, so PKPD characteristic of empagliflozin, dapagliflozin, and canagliflozin. You have here pharmacodynamics. You have here phase 3, selectivity over SGLT1, glucose excretion, duration of action. You have this. Okay, try to compare the three, no? Empagliflozin, dapagliflozin, and canagliflozin. Okay, pharmacokinetics, you have a rapid peak levels for the three. Distribution, moderate volume of distribution. Okay, extensive tissue distribution. Class benefits versus risk. Orally, you have the benefits, but the risk and limitation is in the kidney. You do not give this if the glomerular filtration rate is 45 to 60, more than this, no? More than 45 to 60. Mechanism of action, independent of beta cell function and insulin resistance. You have to limit this use if you have urinary tract infection. And then beyond glycosylated hemoglobin, you have here weight reduction, blood pressure reduction. So these are now the benefits of your canagliflozin. Okay, so these are now your agents and actions. You have here biguanides, sulfonylureas, miglitinides, thiazolidinediones, and alpha-glucosidase inhibitor. And these are now your mechanism of action. For biguanides, it will inhibit glucose production by the liver. Sulfonylureas increase insulin secretion by your pancreatic beta cells. Miglitinides increase insulin secretion by pancreatic beta cells. Thiazolidinediones increase glucose uptake by skeletal muscles. Alpha-glucosidase inhibitors inhibits carbohydrate absorption. To go fast, it's already 9, no? Or 10. Okay, so these are your thiazolidinediones and bile acid sequestrants. Insulin secretagogues, you have sulfonylureas and your exemplified by your glimepiride and glyphosate. GLP-1 receptor agonist, exemplified by exenatide. Amylin agonist, simplified by pramlintide. So this is your egregious 8. Oh no, egregious 11. The different drugs that you can use at the different sites. Okay, so let's go to insulin therapy. At short-term use, you can use this in acute illness, surgery, stress, and emergencies. In pregnancy, breastfeeding, insulin may be used as initial therapy in type 2 diabetes, severe metabolic decompensation such as diabetic ketoacidosis, hyperosmolar non-ketotic coma, lactic acidosis, and severe hypertriglyceridemia. Then long-term use, if targets have not been reached after optimal use of combination therapy, or consider change to your multi-dose insulin therapy. Okay, so insulin regimens. The majority of patients will require more than once daily injection if good glycemic control is to be achieved. However, a once daily injection of an intermediate acting preparation may be effectively used in some patients. Twice daily mixtures of short and intermediate acting insulin is a commonly used regimen. In some cases, a mixture of short and intermediate acting insulin may be given in the morning. Other regimens can be used. A regimen of multiple injections of short-acting insulin before the main meals when an appropriate dose of an intermediate-acting insulin given at bedtime. So this is one regimen that you can use. Okay, so these are the different preparations. You just go through with this. No? So for short acting, you have here Aspart, Glulicin, Lespro, regular, long acting. You have Ditimer, Glargine in PH. You have here insulin combinations. You have here, for example, 75 over 25, 75% Protamine Lespro and 25% Lispro. Okay, so these are now your overview of your insulin and action. You have here your soluble human insulin or Actrapid, Humulin 5 versus your long-acting basal analog. You have Glargine, Lantus, and Ditimer. Okay. So types of insulin, you have here rapid acting, short acting, intermediate acting, extended long acting, analog, and premix. You have here your brand names. Humalog for rapid acting, Novo Rapid. Then short acting, Humulin R and Novulin. Intermediate acting, you have Humulin and Novulin. Then extended long acting, Lantus and Livimir. Premix, you have here Humalog mix. And you have here your dosing schedule. So please try to go through with this one, huh? This is now your more or less peaks of your glucose, breakfast, lunch, and dinner. So normal insulin secretion, breakfast, lunch, and supper. Type 1 diabetes, dosage instructions are entered into the pump small computer, and the appropriate amount of insulin is then injected into the body in a calculated, controlled manner. And this is termed as your insulin pump. Be familiar with this, no? Insulin pump. Okay, now you will now have your continuous sub-Q administration of short-acting insulin using a small pump. The pump can be programmed to deliver basal insulin and spikes of insulin at the time of meals. Requires intense monitoring. No, requires highly motivated patients because failure to deliver insulin will have serious consequences. Okay, so these are now your anti-diabetic medications. Okay, profiles of the different drugs, no? Metformin, DPP-4, GLP-1, ECD, alpha-glucosidase inhibitor, colicibilam, then your insulin, sulfonylureas. Okay, so condition known as diabetic ketoacidosis, serum glucose is usually elevated 250 to 300, but rarely more than 400 milligrams. Occurs within 24 hours, the blood pH is less than 7.3, you will have positive ketonuria or ketonemia. This is a medical emergency for type 1 diabetes. What will be the symptoms of diabetic ketoacidosis? You have nausea and vomiting, thirst and polyuria, abdominal pain, and shortness of breath. So how are you going to precipitating events: inadequate insulin administration, infection, pneumonia, urinary tract infection, gastroenteritis, and sepsis, infarction such as cerebral, coronary, mesenteric, and peripheral, drugs such as cocaine and pregnancy. This can precipitate diabetic ketoacidosis. Other findings, you will have hyponatremia, hyperkalemia, azotemia, hyperosmolarity, PE of your patient with diabetic ketoacidosis. You have tachycardia. You know what is tachycardia? Okay, more than 100, no? Dehydration, hypotension, less than 90/60. Tachypnea. What is tachypnea? Then diabetic cosmal respiration. You know what is cosmal respiration? Uy. This is in your physical diagnosis, no? Respiratory distress, abdominal tenderness, lethargy, obdentation, cerebral edema, and possibly coma. Okay. Treatment. Replace fluids. 2 to 3 liters of 0.9% saline over first 1 to 3 hours. Then 0.45% saline at 250 to 500 ml per hour, and then change to 5% glucose and 0.45% saline at 150 to 250 ml per hour when your plasma glucose can reach 200 milligrams per deciliter. Then administer short-acting insulin. You have the dose here. Or you can give by continuous IV infusion, increase 2 to 3-fold if no response by 2 to 4 hours. Okay, and then do not supplement potassium until the potassium is corrected. Measure capillary glucose every 1 to 2 hours. Measure electrolytes, potassium, bicarbonate, phosphate, and anion gap every 4 hours for first 24 hours. Monitor blood pressure. Replace potassium 10 milliequivalents per hour when your plasma potassium is less than 5 to 5.2 milliequivalents per liter. Okay, so continue above until patient is stable. Bicarbonate is given to correct your acidosis. Okay, so let's go to hyperglycemic hyperosmolar state or non-ketotic hyperosmolar syndrome. What is the difference between diabetic ketoacidosis and hyperglycemic hyperosmolar state or non-ketotic hyperosmolar syndrome? This usually present in elderly individual with a several week history of polyuria, weight loss, and diminished oral intake that will culminate in mental confusion in the elderly, lethargy, or coma. This is also a medical emergency for type 2 diabetes mellitus. How about diabetic ketoacidosis? It is a medical emergency for type 1. Okay, so hyperglycemic hyperosmolar state is a medical emergency for type 2 diabetes mellitus, where you have inadequate fluid intake as the underlying cause. Hyperglycemia is more than 600. It's usually between 400 to 500. The plasma osmolality is 320 or more than that. So how are you going to treat? So abnormalities, most notable will be a marked hyperglycemia, hyperosmolality, and pre-renal azotemia. Treatment, fluid replacement, should initially stabilize the hemodynamic status of the patient at 1 to 3 liters of 0.9% normal saline solution. So 0.9 NSS, no? Then correction of electrolytes. There is usually hyponatremia, IV insulin, and then treat the underlying illness. Okay, so this is now your DKA or diabetic ketoacidosis versus hyperosmotic non-ketotic diabetes mellitus. So you just go through this, huh? Oh, chronic complication of diabetes mellitus, you know this already, microvascular, the eye, sensory, kidneys, coronary heart disease, peripheral arterial disease, cerebrovascular accidents, gastroparesis, uropathy, dermatologic, infectious cataracts, glaucoma, then hearing loss. Okay, hypoglycemia, the cause is missing the meals, symptoms, tachycardia, palpitation, and sweating. How do you treat a patient with hypoglycemia? You have to give candies. White rabbits, no? The one I told you before, no? Sugar, IV glucose in the form of D50 water, you inject that. Then glucagon, 1 gram intramuscular. Dawn phenomena is a combination of natural body changes, ay nako. The last among the slides is your Somogyi effect. This is your rebound hyperglycemia, high morning blood glucose preceded by an episode of hypoglycemia. The body counters by releasing hormones to increase blood glucose. So what is the only safe to treat diabetes long term? Don't develop it in the first place. So prevention is the best medicine. So I will give you to the questions, no? How do I exit and go to the next?
You want to leave the
Uh-uh.
teams though?
No, I don't want to leave the teams. I'll go to the another PowerPoint. I will give them a sort of 4 question.
Is the PowerPoint already opened up? Or you, let's open first the PowerPoint.
Since I'm not Stand.
Loading. Any documents?
Another lecture lang. Sa access. Lain na PowerPoint.
Hmm.
So, ano ko sa WPS?
Ano siya sa mga any document? DM1? DM1 apply?
Hindi.
Hindi ko ka-open sa Microsoft.